In this video lecture, we're going to review the prevalence and course of psychotic disorders with a focus on schizophrenia. The prevalence of psychotic disorders can be a bit more difficult to evaluate than the prevalence of some of the other disorders that we have discussed because it is less common. So even in these large-scale epidemiological studies, like the National Comorbidity Survey, because of the low prevalence of these psychotic disorders, even in those very large representative samples, we are not going to expect to find many cases of these psychotic disorders. So we're less confident in our estimates of the prevalence of these disorders, but these prevalence estimates that I'm going to give you are our best guesses based on the information that we currently have from the United States and from global studies of the epidemiology of psychotic disorders. So evidence suggests that a little bit less than 1% of individuals in the United States and worldwide meet criteria for schizophrenia. And this prevalence is pretty stable cross-culturally. So we tend not to see major differences in the estimated prevalence of schizophrenia across countries or across different regions of the world. Schizoaffective disorder, we see a lower prevalence, so about 0.3%. And in studies that have compared the prevalence of specific psychotic disorders, schizoaffective disorder appears to be about a third as common as schizophrenia. Schizophreniform disorder, we don't have enough studies looking at the exact prevalence of schizophreniform disorder, particularly because we know that many individuals who meet criteria for this disorder will eventually go on to meet full criteria for schizophrenia. But the evidence suggests that it's about 20% as common as schizophrenia, so about a fifth of the prevalence. Brief psychotic disorder is also interesting. It's really challenging to identify the prevalence of this disorder because sometimes discrete episodes of psychosis may occur in the context of other disorders. So for example, a first episode of psychosis might be a manic episode in bipolar 1 disorder. It may be a mood congruent psychotic depressive episode in bipolar disorder or unipolar depression. It could be the first onset of psychosis in one of our other psychotic disorders, or it might be brief psychotic disorder. But reviews looking at individuals' first onset psychotic episodes suggest that about 1 in 10 of these individuals are experiencing a brief psychotic disorder. So this is a psychotic episode that is not reflective of another disorder, may not necessarily represent increased risk for subsequent psychotic episodes, but is this kind of single psychotic episode that has this rapid onset and resolves within a month. Delusional disorder is another disorder with very low prevalence, so estimates suggest around 0.2% of individuals. And finally, schizotypal personality disorder is the disorder that we have the most difficulty identifying prevalence estimates for. So studies have identified a prevalence anywhere between 0.6 and 3.9%, depending on the population under investigation and how they are assessing and diagnosing this personality disorder, characterized by these less severe symptoms that are similar to psychosis but not fully psychotic. So this suggests that the prevalence of schizotypal personality disorder is higher than the prevalence of these full psychotic disorders, but lower than many of our other disorders. For course, I'm going to focus on the course of schizophrenia as opposed to the other psychotic disorders. The course of schizophrenia tends to have its onset in adolescence or early adulthood. So interestingly, in schizophrenia, we tend not to see gender differences in the overall prevalence of the disorder, but we do see gender differences in patterns of onset. So typical age of onset for men with schizophrenia tends to be late adolescence and early 20s. So a common time that you'll start observing the emergence of symptoms or experience of functional difficulties is sometimes around the time that an individual is graduating from high school and starting college. In contrast, onset for women tends to be later, so late 20s and early to mid 30s. So you can imagine that the developmental stage at which these symptoms occur is pretty different for women compared to men. So women may have completed their formal education, they may be in jobs, they may be married, they may have families or children. So even though the prevalence of schizophrenia tends to be comparable between men and women, we do see these gender differences in the timing of onset. Schizophrenia tends to be a chronic disorder, and we can characterize the course of the disorder by talking about several different phases of the disorder. So the first phase is what we call the prodrome. So this is the period of time during which an individual has not experienced psychotic symptoms, but during which we start to see the emergence of symptoms and changes in behavior that are suggesting the development and progression of the underlying symptoms and processes that will eventually lead to the psychosis. Often the prodromal time is characterized by primarily negative symptoms. So you might see social withdrawal, you might see a decrease in behavior. If an individual is in school, you might see a decrease in school performance. If they are employed, you might see the emergence of difficulties at work. So during the prodrome, we are starting to see changes in behavior and sometimes the emergence of problems, but we are not seeing active psychotic symptoms. The active phase is characterized by the presence of psychotic symptoms. So we might be seeing delusions, hallucinations, disorganized thoughts, disorganized behavior. So the active phase is when an individual is exhibiting those positive symptoms. And then often what we will see over the course of the disorder is kind of periods of active symptoms interspersed with what we call the residual phase, where an individual is not experiencing a full psychotic episode, but may continue to have difficulty with symptoms. And often this residual phase is characterized by more negative symptoms. So even if the positive symptoms resolve or are treated with medication, we will often continue to see these residual negative symptoms. So alogia, that decrease in speech and thought, avolition, social withdrawal, and impairments in functioning that go along with those negative symptoms. So the course of schizophrenia tends to be chronic, even with treatment. Many individuals stabilize about 10 years after diagnosis, so they may not achieve a level of functioning or a level of symptoms that is consistent with what they experienced before the onset of the psychotic episode, but they'll often attain a stable level of functioning where they are having their symptoms are managed through medication or through other means. So often this disorder is chronic and people will continue to experience psychotic episodes and to require treatment, but it does tend to stabilize after a period of about 10 years. The long-term prognosis of schizophrenia is very variable. So there are some individuals who are very impaired by their symptoms of psychosis, and there are other individuals with schizophrenia who continue to have significant symptoms, but who attain very high levels of functioning. So we know that there is increased morbidity associated with psychotic disorders. Some of this is associated with symptoms of the disorder. So for example, behavioral disorganization that can put people at risk for physical harm. And we also see morbidity associated with the treatments for the disorder. So when we talk about antipsychotic medication, we'll talk about some of the side effects of the most commonly used antipsychotic medications. They can include metabolic syndrome, weight gain, and type 2 diabetes, which can contribute to increased morbidity. We also see increased mortality. Individuals with psychotic disorders tend to have a decreased life expectancy compared to the general population. Again, some of this can be attributed to the symptoms of the psychotic disorders. Estimates suggest that between 10 and 15% of individuals with a psychotic disorder may ultimately complete suicide, and we know that psychotic symptoms are a risk factor for suicidal behavior. And this increase in mortality can also be somewhat attributed to some of the side effects of the medications that are used to treat these disorders. So from other health conditions that are associated with some of the side effects that are used to manage the symptoms of psychosis.